start it from your end.
You have to.
Yeah, I'm trying, but you have to first allow that.
No, you've been allowed to share your video, sir. There is no.
Oh, I cannot start because the host has stopped it. It's telling me.
Okay, let me just check again. Just a minute.
Yeah, please. And we have Dr. Ravi Kanojia also, who's the secretary of our parent association, Indian Association of Pediatric Surgeons. And he's helping us tremendously in hosting these webinars for the audience. Hello, Dr. Ravi. How are you?
Hello, Dr. Miglani. I'm good. Thank you. Good evening, everyone. Good evening, Dr. Dixon.
Dr. Ravi, I should acknowledge that you are doing a very fantastic job as a secretary of IAPS, and all the chapters are doing, I think, pretty well, coordinating with each other and with IAPS also.
Thank you very much.
And congratulations for that. Yeah, now I can see myself also. Thank you, Nitin.
Sir.
I think just, yeah. So are we online now? Should we start? Or
we have 3 minutes remaining, and now the YouTube link is also started by Dr. Ravi Kanojia.
Okay. Okay, we'll wait for another couple of minutes, and then I'll be starting with the introduction of Professor Izo Hayama. How do you pronounce your name, Professor Hayama? Is it Izo or Izo?
APSO is the
Izo. Hayama.
correct announcement. Hayama.
Yeah,
Okay.
all right. Nitin, have our EC members joined, most of them?
Yeah, Dr. Manish Patak has joined, and I saw Dr. Basant joining in. And I think Madam Sushmita also have, sorry, I've allowed her to join in, but I can't see her name right now.
So you can coordinate with Dr. Pathak, because I think Dr. Anjan was busy today.
Yes, he spoke.
Join a little late,
Good
so
evening.
you will be monitoring the chat and the questions that come from the audience.
Right, sir, right.
So good evening, everyone. I'm Dr. Sushmita Bhatnagar.
Hi, Sushmita, welcome.
Very nice to see all of you and to waiting to hear from ISO.
Yeah, everyone is waiting there. And
yes, I know.
in a minute or so, we'll be starting with the things without much of a delay. So that we're just waiting for little, everybody is joining at the moment. So the number is ticking. We have 36 participants in the Zoom. So very soon we'll be having somewhere around 75, 80, 100 numbers. I think by the time we touch around say 45 or so, we'll be starting. What say? Dr. Nitin, is it okay?
Yes, sir. That's good, sir. And I'd like to welcome Professor Ram Samoj. Welcome, sir. Thank you for joining in. Sir is the head of department at the Postgraduate Institute in Chandigarh. Good evening, sir, and welcome.
Good evening, Nitin.
Good evening, Dr. Ram Samoj. Very nice to see you.
Good evening, Dr. Miglani. कैसे हैं भैया?
Very fine, sir. Very fine.
Thank you.
Sir, it's Miglani sir, it's 7 o'clock. I can just start
Yes,
the
we
meeting
can
and then
start
you
now.
can.
Yes,
Yes.
I think we can start.
Right. So good evening, everybody, and welcome to the third International APSO webinar. We've tried to get a host of eminent personalities who are big scholars and stalwarts in their field. And Professor Iso Hiyama from Hiroshima University has kindly consented to give us a lecture on his topic of liver tumors, which is his forte. And without much ado, I would request our chairperson, Dr. Miglani, to introduce Professor Iso formally. Over to you, Miglani, sir.
Yeah, thank you, Nitin. At the outset, I would welcome everybody to this third APSO webinar. Due to COVID, if you know, we are not able to hold physical meetings, and in an effort to continue with the academics and not miss out on, conferences and all. So this initiative by IAPS is giving us dividends, and we are updating ourselves. In the process, today, we are honored to have a very eminent speaker from Japan, from Hiroshima, Professor Izo Hiyama. Professor Izo Hiyama is an eminent surgeon in pediatric oncology, and he did his education from Hiroshima University School of Medicine and in 1982, and did his postdoctoral degree, that is PhD, in 1989 from Hiroshima University, Japan. Professor Hiyama is a very eminent person. He passed did his residency from 1982 to 1989 in Hiroshima University Medical Hospital. He was a research associate in Hiroshima University from 89 to 94, assistant professor in Hiroshima University from 94 to 2001, associate professor from 2001 to 2004, and then he's visiting professor, Children's Hospital of Los Angeles since 2001. Professor Izo is a professor and natural science of basic research and development and Department of Pediatric Surgery in Hiroshima University Hospital since 2004. He is chairperson of Japanese group of pediatric liver tumors since 2008 till date. He is also executive board member of Japan Children Cancer Group, that is JCCG. Am I there?
Yes, we can hear you, sir.
Okay. And he is chair of the Liver Tumor Committee, Japan Children's Cancer Group since 2015. He is executive president of the Japanese Society of Pediatric Hemato-Oncology from 2015 to 2018. He is also the executive member of APSO. He is also he was APSO local program committee member in Kyoto in 2018 in the annual meeting. And he chaired an annual meeting of Japanese Society of Pediatric Hemato-Oncology 2018 to 2019. He is member of Surgery Discipline Committee from 2016 till present. And he's a member of multi-center trial of all stages of hepatoblastoma and hepatocellular carcinoma from 2017 till date. His research subjects are pediatric oncology in solid tumors, pediatric surgery, molecular medicine, surgical infection, clinical genetics and cancer, and regenerative medicine. Professor Izo is a very awarded and a decorated person. He has been awarded with awards for Japanese Children Oncology Society in 1994. He's been awarded from Hiroshima Cancer Seminar in 1995. He's had the Kaushin Kai Award in 1996, the SIOP Award in 97, Clinical Cancer Awards of International Journal of Oncology in 2006, and SIOP Award for Clinical Trial in 2015. Professor Hiyama has published 621 papers in national and international journals, which are in English literature. if I go on reading the papers, I think we'll have to have another webinar for Professor Hiyama, then I'll be taking away all the time. So without much of ado, I would request Professor Hiyama to start his talk on pediatric liver tumors. Over to you, Professor Hiyama, and thank you very much for accepting our invitation once again.
Okay, thank you. Can you hear me? So, thank you for the very kind invitation and introduction of me for the Dr. Magrani. Okay. Today I appreciate for giving me to have a talk about pediatric liver tumor. I'll share my slide now. So, can you look my screen? It's okay? No problem?
Yes, we can see the screen.
Yeah. So today I appreciate for giving me to have a talk about tumors, liver tumors. So there are nothing to be disclosed. In the in liver, pediatric liver malignancy, 90%, about 90% of hepatoblastoma. Today I focus into this hepatoblastoma. It is incident but rare. So in Japan, about 80 to 100 cases is diagnosis a year. And cisplatin is used as a first-line chemotherapy. And the induction of liver transplantation has been extended. As shown in this slide, the operative chemotherapy reduces the size of the tumor like this, and the tumor becomes resectable with preserving main hepatic vessel. To improve the outcome and reduce toxicity in such cases, global study is needed. Before 1990, survival rates of childhood liver tumor were poor in Japan, like this. Even if the tumor was localized. Similarly, the outcome of all survival in sample group were about 35% up to 1982, but those with standard risk hepatoblastoma improved at about 90%. So how this progress have been achieved? The usage of cisplatin and anthracycline is effective to primary and metastatic tumor, so that the rejection rates increased and then the outcome of patients has improved. However, moreover, new surgical approaches, including hepatic exclusion, Pringle procedure, ultrasonic dissection, argon beaver zone, contribute to the safety and accurate surgical resection. And multi-center cooperative studies such as CIPO, COG, and JPLT, GPOH are also important for this progress. This case shows the pretext 2 tumors, very small tumor like this. We use the QSER for the resection and coagulation powder for preserving or bleeding from the resecting margin, like this. In Japan, we established a full Japan study group, so-called JPLT, at 1989 to evaluate the efficacy of cisplatin and pirarubicin, so-called CEDAR regimen. JPLT-1 protocol was conducted between 1991 and 1999. Then JPT2 protocol was launched out on 1999 to evaluate the cure rates of risk stratified hepatoblastoma using pretext system. This first-line regimen is so-called SHITA in JPT study. SHITA involving cisplatin and pirarubicin. Pirarubicin as a derivative of doxorubicin is considered to be less cardiac toxicity compared to doxorubicin with the same dose and same effect. In original SHITA regimen, we used 80 milligram per square and of cisplatin and 60 milligram per square of pirarubicin. JPLT study used the pretext classification for evaluation of tumor extension. This system is based on quinone segmentation of the liver. The liver segments are grouped in 4 sections, 1, 2, 3, 4. This classification was first described by Circle Group and depend on the number of continuous sections with a tumor. There are 3 sections, the continuous 3 sections is here, this is pretext 1, 2 is the 2, 1 is the 3, there's nothing the 4. And another component of this classification is annotation factors. These definitions were revised in 2017. Mainframe on JPLT protocol strategy was shown in this slide. All pretext 1 cases underwent upfront primary tumor resection. And pretext 2 cases usually underwent preoperative chemotherapy and then resection. In the remaining cases, mainly advanced pretext 3, 4, and metastatic cases, after 2 courses of preoperative first-line chemotherapy procedure, and then we evaluate the response of the tumor. In the responder, we added more CETA regimen, 2 or 3 courses, and then surgical resected this tumor. In non-responder, we use a second-line chemotherapy, so-called ITEC regimen, consisting of ifosfamide, carboplatin, pirarubicin, and etoposide, and then we go to the resection. In some aggressive cases, we use mega chemotherapy with stem cell transplantation. This shows the survival rates of JPLT2 study. As you can see, the survival rate of STRATA1, this upfront resection is not so good, and megactherapy with stem cell transplantation was not so effective here. This case has a small pretext 2 cases here. As segment 6, we resected this tumor with non-anatomical resection, like this. This case is pretext 2 tumors with portal tumor thrombosis, like this. Are defined as annotation factor, so-called P2. After preoperative chemotherapy, this thrombosis diminished here. So standard left hemihepatectomy was performed in this case. This is the portal vein. This tumor is the pretext 3 cases, which located the segment 4, 5, and 8 after the shrinkage of tumor by chemotherapy. This is you can see the nicely shrinkage of the tumor. We perform the central 2 sectionectomy here for preserving liver function. This case had pretext 3 tumor originated from caudal lobe, and this case had a lung metastasis like this. After preoperative chemotherapy, the primary tumor largely shrink and like this. So we rejected this tumor by left extended hepatectomy. And in this case, we also rejected lung metastasis at the same time here. This case, the survival was event-free. And this shows a living donor liver transplantation here. So now is for the treatment of advanced liver tumors, extreme rejection and liver transplantation remain controversial. So extreme rejection, we needed safety margin, especially all hepatic vein and portal veins. And the rescue transplantation might have worse survival. And in liver transplantation is for the unresected tumor, but this is a needed immune suppression. Among JPT2 patients with hepatic malignancies, 32 showed spontaneous tumor rupture at diagnosis, like this. These peritoneal ravage. So we define tumor rupture as free fluid in the abdomen or pelvis at diagnosis is one or more of the signs shown in this slide. Internal complexes separation with the fluid, high density fluid on CT more than 30 Heinz field units, heterogeneous fluid on ultrasound with echogenic debris, visible rupture, hepatic capsule, direct on image. In this case, intravenous radiology through left femoral vein revealed the tumor vessel of the peripheral right hepatic artery here. And extravasation indicated intra-abdominal bleeding due to tumor rupture. TAE was effective for stabilization of circulating dynamics in this case, but the bleeding of the tumor remained. Therefore, we performed the resection of tumor after TAE. So you can see the rupture hepatoblastoma like this. This shows the survival rate of the cases with ruptured hepatic tumor and the total JPT2 cases. This is total JPT cases in the progression-free survival and overall survival like this. This is the green line that protects 1 to 3 the ruptured hepatoblastoma, but they underwent delayed rejection. And this blue line is upfront rejection for the uncontrollable bleeding in this protects 1 and 2 or 3 hepatoblastoma. Red is a pretext 4 with ruptured cases. So you can see these cases underwent initial rejection of the ruptured cases not so good. So this is maybe the causes stratum 1, the outcome is not so good in stratum 1 cases. So no rupture detects 4 cases survive. And the outcome of the case whose tumor margin was microscopically positive is also controversial. In the previous cycle report, there was no significant difference in the outcome of the patient whose margin was microscopically positive. This is the microscopic positive. This is the rejected margin. In the JPLD study, this shows the event-free survival rates of cases with microscopic positive margin bunch of rejection here compared the incomplete rejection cases in non-metastasis cases here, the all rejected cases. The cases with microscopic positive rejection showed poor outcome in the comparison of complete rejected cases. So recently we tried the ICG navigation surgery for detection microscopic residual at surgical margin like this. Using this method, microscopic residual might be expected to decrease in the recent trial. So you can see the nicely ICG positive nodule here. And there are small ICG positive nodule in the here. Usually the injection ICG 3 to 4 days before abdominal surgery. There were examples for micrometastasis under navigation surgery for lung. You can see the metastasis here nicely, a ICG positive nodule. For detection of lung metastasis, we injected ICG 1 day before thoracotomy. This region was here too difficult to identify by naked eye, but these regions were distinguishable by ICG navigation. Here, we can detect it less than 0.1 millimeter metastasis. In this case, pulmonary metastasis almost here diminished by chemotherapy. Before liver transplantation, we performed exploratory thoracotomy using ICG navigation. So there you can see the very slightly positive ICG nodule here. So this HD staining of the detected specimen here is suspected metastatic size, small microscopically metastatic size. So using the fluorescence microscope for ICG detection, we can identify ICG positive visual tumor cell in lung. TACE is a combination therapy of TAE and regional chemotherapy because hepatic malignant tumor is mostly dependent on supply on hepatic artery. The embolization interrupts the arterial blood flow to a tumor and prevent the washout of the injected chemotherapeutic agent for a tumor. We are trying some cases of the TACE protocol. This is the hepatoblastoma case was underwent TACE. This case was 9-month-old female with a pretext B hepatoblastoma. Here. TACE using carboplatin and pyridoxine was performed by her right hepatic artery. This tumor is markedly shrunk after 2 courses of TACE. Like the outcome of the patient who underwent TACE is equivalent to that of the patient who underwent systemic chemotherapy. Here. This may be the TACE is effective or a localized large hepatoblastoma. So finally, I would like to introduce a global collaborative study of pediatric liver tumors. As you know, there are 3 major group 4 multicenter trials for pediatric liver tumors, SAPAL, COG, and JPLT. So primary rejection, surgical rejection for resectable tumor has been an integral part of the treatment strategy for patients treated in JPLT study and as well as COG-based trial. In contrast, SAPAL based trial using undergo resection after receiving neoadjuvant chemotherapy in all cases. In 2011, we conducted MOU with Children Hepatic Tumor Consortium to produce an international database in Los Angeles among COG, CIFL, and Asian group. As a result, we made a new database consisting of 8 trials. Here are the 2 trials of COG, 2 trials of CIFL, 2 trials of GPOH, and 2 trials of JPLT, and the total of 1,605 cases database. And then we analyze these database. After the multivariate analysis of these factors, we made new international risk stratification, which was published in Lancet Oncology 2017. This divided hepatoblastoma into 4 groups: very low, low, intermediate, and high-risk hepatoblastoma. This shows a cartoon for risk stratification. This is predicts one. So this is a very low. This is maybe resectable at diagnosis. It's a very low group, and green is a low group, and yellow is intermediate. This is the predicts one metastasis positive. It go to the high risk. This protects 2 groups. This is 3 and 4. This is the cartoon go to the risk stratification. This is schema of data management of a new global study of FIT trial. This global study will be performed as a 3 individual consortia. This is a COG group and a CIPAL group and our Asian group, and the merge in this is go to the Shineka system. And now we are Asian group, including with Gansu, Singapore, and Hong Kong, participate in our GCC consortium. We propose this the FIT protocol. This is a framework of FIT protocol. So, including in the hepatoblastoma as well as hepatocellular carcinoma. The IM this trial, resection of toxicity in good prognosis tumor, very low or low groups, and intermediate groups, and improve outcome for poor prognosis tumor, group D. So hepatocellular carcinoma is stratified the 2 groups, resectable and unresectable or metastatic hepatocellular carcinoma in children. This shows the primary objective clinical outcome in all patients, validation of new global risk stratification, and evaluation of critical evaluation factor, and the collection of clinical and pathological annotated biological sample is included. This shows the sample size of this study. Approximately 1,200 cases is target cases, and 20% of them are expected in our Asian group. This slide shows a schema of imaging center review system in our JCCG group. The DICOM data here include CT and MRI sent our data center from the E institution, but now is also sent in the cloud system. And then radiologist is the upload is the data storage is this cloud system. And then radiologist access this system. The process should be done a real-time review. In addition, using imaging during treatment, central reviewers also evaluate the treatment effect and detectability. In this setting, all investigators, including surgeons, oncologists, pathologists, can be accessed this storage data for discussion. The CRF data will be uploaded in the database using the same platform from Europe and Asia here. But the collection is independently, like this. And then these data was merged with COG data, and then data will be able to analyze in each consortium as well as the merged data. The current status of HIT trial is shown in this slide. The number of registered cases not reached to the target number, but gradually increased because of increasing of participant countries and institutions. So this is now our Asian group with Hong Kong and Gansu and Singapore institute already joined our consortium. Please join our FIT trial from Asian group. Thank you for your attention.
Thank you, sir, for that wonderful talk on hepatic tumors and especially introducing the FIT trial to us. And I'm sure there are a lot of questions. So I would like to request Dr. Manish Pathak. Dr. Manish, could you start with the question and answer session?
Thank you, Professor ISO. There are a lot of questions. There is a lot of interest on TACE and ICG. So one of the questions is that what is the indication doing ICG? When do you consider?
This is the indication of a TACE.
Indocyanine green imaging, ICG imaging. When do you
ICG
do
imaging?
ICG? Yeah.
So we are used now the all hepatoblastoma cases with the ICG navigation. So we usually liver hepatic resection. We injected the ICG before 3 or 4 days before surgery. Because the ICG, as you know, the ICG is uptaken into liver normal hepatocyte and export to the bile duct. So this is ICG is remaining the bile duct. So if we injected ICG 1 day or 2 days before surgery, so we get to the enough time to diminish our ICG from bile duct. We should inject ICG more than 3 days before surgery. Okay, so we are the an irrigation surgery of liver resection. We are using very nicely to ICG detector. This ICG detector is very comfortable and using a very broad field or dermatology or breast cancer field, or as you know, the lymphography or another angiography. And if you perform the pulmonary metastasiectomy, this ICG permitted 1 day before surgery. This is a very good timing for ICG navigation for the pulmonary surgery. Okay.
Okay, thank you. So if I'm understanding it correctly, then it is that you use ICG in all cases of hepatic tumors, and it helps you in detecting the margins, whether the margins are positive
Yes.
or not.
Yeah.
Yeah.
Margin also ICG is a detector margin. Also is a this is useful for detecting the small intrahepatic nodule. So such as where the multiple type of hepatoblastoma. Also, with ICG is very useful for pulmonary metastasis.
Yeah, thank you. So another question is related to TACE. So what
Okay.
is your protocol of TACE, and what are
Yes.
the implications of using TACE?
So we try to the test protocol in the JPJ1 study. So we are this is the test is indicated localized large tumor. This we don't indicate it to the metastasis cases. So we try to the test for the carboplatin and pyridoxine instead of systemic cisplatin and pyridoxine protocol. We are trying to the 1 or 2 or 3 courses for the same time of the CETA protocol in the JPLD1 study. So we compare the systemic chemotherapy and TACE groups. So it's a result of the outcome of the not so the already or equivalent of TACE group and systemic chemotherapy group. But the TACE is very difficult to do the very small patients. So now we are very restricted institution is now is using TACE. But the large tumor is very effective in TACE is very effective largely localized tumor we support.
Okay, so you use it in localized tumors?
Yes,
and
localized large tumor.
Okay, and you did a study where you compared systemic chemotherapy versus a chemotherapy by TACE.
Yeah.
That's what you, yeah. Okay. So what were your results? Means which one did you find better? Means TACE or versus the systemic chemotherapy protocol?
So, well, JPT1 study, the result of the TACE is not so super effective than the systemic chemotherapy group. So as you know, the TACE is for the children is technically is difficult. So we are now the used to the systemic chemotherapy in JPT2 or 3 study, not we recommended TACE. But we are tested recommendation for the very localized right tumor or another such a ruptured hepatoblastoma.
Okay, thank you. Another question is regarding the impact of tumor histology on outcome.
Yes, very most critical problem. This is well, as you know, the undifferentiated small round cell tumor is very poor outcome. But fortunately, in our Japan or Asian group, this is such a small cell undifferentiated type is very rare. But in the COG or cypher group, some cases show the undifferentiated small cell round cell tumor type, SCAT type, but this type is show the poor prognosis. But recently, pathological review, such cases involve the rhabdoid tumor in liver. So rhabdoid tumor is also a very poor prognosis. So if the rhabdoid tumor is detected, we should do the different chemotherapy or different treatment strategy for such a liver hepatic rhabdoid tumor.
Okay, thank you. Dr. Nitin?
Yeah, sir. So there are a few more questions. Thank you, Dr. Manish. So one of the questions in people who don't do, a lot of hip liver resections is about vascular control and vascular isolation. So what is your trick and what is your technique and what would you share about vascular isolation and vascular exclusion before going in for a hepatectomy?
So this is we use a combination of some difficult cases to the isolation of hepatectomy, or we are used to the QSA or QSA system to resection. But unfortunately, in the pediatric hepatic tumor do not so have a cirrhosis, so we can use the hepatic isolation is very comfortable to use the such cases. So this is a very conventional section is comfortable, but the QSA or argon laser is very useful to detect resection of hepatic tumor.
Right. Thank you, sir. That clears out a lot of things. Dr. Ravi Kanoja has asked, do you have any experience with radiofrequency ablation? And is it used in your setup RFA?
Ablation?
Ablation, radiofrequency ablation. Yes, sir.
Ablation is it is a very tumor ablation is not used to. I don't have so many experience for ablation. In the other field, sometimes used the ablation for the HTC cases, but we don't have not so many experience for the hepatoblastoma cases.
Okay, right, sir. So yes, that even we use RFA in adult patients more often than in pediatrics. So Dr. Sushmita Bhatnagar has asked if fetal histology does not respond to monotherapy and does not respond to Plado, then what are the other options? You've mentioned a few in your presentation. Could you just go over non-Plado options for chemotherapy?
Pardon?
Yeah. So if the hepatoblastoma does not respond to monotherapy, especially a fetal histology one, and does not respond to Plado, then what are the other options in?
We have tried another chemotherapy. We are used we are the collaboration study of COG. We tried the vincristine and irinotecan chemotherapy. This is some effective of some cases who are resistant of the cisplatin or anthracycline cases. But now we tried another agent, temozolomide, but we combined the vincristine, irinotecan, and temozolomide trial. But the temozolomide is very show the side effects. So we are now how to use the temozolomide for the targeting to the hepatoblastoma is effective or not. We are now under consideration for the effectiveness on the side effect of this protocol. And
right. So
in the FIT trial, we ice arm for the resistant cases. This is a randomized trial that we don't know how to be effective, but we are now that try to the ice in the resistant cases.
Okay, sir. So ICE is something to be used at resistant cases. That is the take home from this question. And I'll ask Dr. Manish. Dr. Manish, any more questions which you have looked at?
Yes, thank you, Dr. Nitin. There is one more question Dr. Vinita has asked regarding in cases of ruptured liver tumors, initial resection versus delayed resection. Is which one do you consider?
So,
And
as you know, the in JPLT study also as COG study, so upfront initial rejection did not have so good outcome because in our JPLT study is such the recurrence of the cases who underwent upfront rejection may be the depend on the rupture case. And another is non-anatomical rejection is risk for the recurrence. So we recommended the anatomical rejection for the if you would like to initial resection for before chemotherapy. We have only permitted pretext of 1 or 2 cases and preserving the main central hepatic vein. So if the tumor is the safety margin from the safety central hepatic vein or maybe the 1 centimeter or so, we recommended initial resection using hemihepatectomy preserving central hepatic vein. And another case, if it is a contact to the hepatic vein or so large tumor, we have recommended the preoperative chemotherapy.
okay, thank you. So basically, if we can do hemihepatectomy safely with an adequate resection margin, then you will go
Yes.
ahead with initial resection, otherwise
Yes.
delayed resection. Okay.
Yes.
Thank you.
Yeah.
Thank you. I think all the questions have been answered. Dr. Nitin, did you come across
Okay,
any
so
other question?
one more question. It is my personal question. In countries like ours, in India, like we don't have many options of liver transplant, especially for pretext 4 disease. So what is your take? There is a lot of literature on extreme resections versus liver transplant and outcomes. So sir, what is your take and your experience say about extreme resections when liver transplantation is not an option, which is very common to most of the South Asian countries?
So this is most critical on the controversial problem. So this is such advanced that maybe the extended cases we are now the discussion with the indication of liver transplantation or extended rejection. So if the cases have remaining distant metastases, especially for lung metastasis, we recommended the extended rejection. So usually the liver transplantation permitted with no remaining distant metastasis. This is a necessary factor for liver transplantation because using the immune suppression after transplantation. But now is a very safe and safety is for liver transplantation. We have now our institutions who how to indicate the liver transplantation localized pretext 4 cases or multifocal cases is also indicated in the liver transplantation. So in COG group, multifocal hepatoblastoma is indicated, all multifocal indicated liver transplantation. But our JCC group are not so in the dependent institution. If the chemotherapy effective, this is we try to the extended resection, which even if the multiple focality cases. Well, because the rescue transplantation is the outcome of rescue transplantation after resection is poor by the previous report by Otto, maybe the 10 years or 20 years ago. But in our recent cases in the rescue transplantation, not so is not so worse. So there is the equivalent data outcome of the cases who underwent rescue transplantation. So we are now treated in our JCC cases, we now recommended, if possible, the extended resection. If impossible or recurrent or remaining some major cases, so we use to the second look or liver transplantation. Make sense?
Yes, thank you, sir. So it's an ongoing debate, and I think the Eastern groups are more towards extreme resections as compared to the COG, like you rightly pointed out. And the multifocality with lung metastasis is obviously a contraindication. So thank you, sir. We have two more questions, sir. One, Dr. Mohammad Arshad has asked, what is the role of bench surgery, or do you have any experience or any
So
opinion
this
on
is a
bench
very
surgery?
difficult. So the bench surgery, I have only one or two cases experiences. Very difficult to the bench surgery, but it may be some transplantation surgeons is very try to do the bench surgery. I don't know so many cases bench surgery.
Right, sir. And one more question is that what is your experience with vascular thrombus and especially portal cavernomas in hepatoblastomas, and how do you tackle those? This is from Vinita.
This which thrombosis? The portal thrombosis? No.
Yes.
Yeah,
Portal,
we are portal or hepatic vein thrombosis, or we are now some cases with portal thrombosis. We are some rejection of partial rejection of portal, and when we try to the hepatic vein thrombosis, we also we joined the cardiac surgeon, so we try to remove the thrombosis or in the main hepatic vein or inferior vena cava. Also, we recent cases we are intracardiac thrombosis.
Okay. Thank you. So, any other questions, Dr. Manish? Would you like to take any more questions if there are any more?
I think we have covered all the questions, and we do not have any other question.
Right. So we have on the YouTube link, we have a question about, sir, what is your, Dr. Rajendra Sauji from Nagpur has asked, what is your experience with hemangioendotheliomas and large hemangiomas, and what is your diagnostic approach?
Large tumor, I already have too expensive, but not so good outcome. Very difficult to dissection in these cases.
Yeah. And Dr. Bagdi, who's a senior pediatric surgeon from the country, has asked, do you have any experience with inflammatory pseudotumors of the liver? Inflammatory pseudotumors.
Inflammatory solid tumor. I also experienced several cases in inflammatory solid tumor. It's a major, but these tumors are very usually large tumor, but it's a resectable. So we are rejection of such tumor.
Right, sir. So thank you. We've covered all the questions, and it has been immensely wonderful having you here, Professor Iso. And I must tell, we have viewers from all over the world, right from South America to the Middle East to Indonesia and India, Pakistan, Bangladesh. And it has been a great success. We've had more than 120 people who have joined in. So I'd like to thank you, sir, for joining in, and last words by our chairman, Professor Dr. Miglani. Dr. Miglani, sir, your comments, sir.
Yeah,
thank you for nice.
Thank you, Professor Iso. It was a very enlightening talk, and Very good discussion followed. We cleared most of our doubts. Most of the participants, sent questions which we face because of our resource constraints and our kind of setups that we have in our country. And surely your lecture was an eye opener for many, and it was a progress in the right direction. I am grateful that you accepted our invitation and delivered this wonderful oration today. And I thank all the participants also who have listened to the excellent lecture, as well as participated by, throwing their questions at us. Thank you very much, Nitin Peters and Dr. Ravi Kanodia, of course, IEPS Secretary, who have made this possible for us to interact with Professor Izo Hayama. Thank you very much, sir, and have a very good night. Thank you very much, everyone.
Thank you so much, Navlini. So, if you interested in FITRAL, please contact our email. So I will discussion to how to join this global trial.
Yes, sir.
Professor Iso, could you just put in your email ID in the chat box so that everybody would be able
I will
to,
send to the yeah.
We can circulate the email on our group, and like we circulated the flyer, we can there's Iso at Hiroshima uac.jp.
Yes,
we can circulate it. Yeah.
Sure, sir. Sure. So we've had a lot of viewers on YouTube also. So thank you. And I'd like to, for all the viewers in India, I'd like to say that Dr. Iso has, the talk started at 10:30 p.m. Hiroshima time. So he's gone out of his way to give this talk late in the night from Japan. We really appreciate you. Thank you, sir. Thank you so much.
And we'll be,
can you hear me?
Yeah, we'll be sending an official certificate also to Professor Izo. APSO certificate. Thank you very much, sir. We'll be sending you.
Thank you. I'll send my slide to the Nichi, so please access my slide. Okay.
Can we have a YouTube recording? The YouTube link be uploaded?
Yeah.
Yes,
no
we'll
problem.
Take care of that. Thank you.
Thank you, everyone.
Right.
I think we can close. Nathan.
Right, sir. Okay. Thank you, everyone. And thank you all senior faculty.